Prof. So today, we are going to have a session with Prof. Sorry, because some person is still entering. Okay, so we are going to have a session with Prof. How entitled on with regard to how we deal with the complication of lung cancer. So without further ado, I would like to invite Prof. How to continue with the session.
Hi, good morning. The notice was very last minute, so I got no time to prepare any slide. So what I do is, that's why actually initial topic that given to me was talking about paraneoplastic only, but I'm going to talk to you about managing complication of lung cancer, which just happened. I was giving this talk yesterday in one of the meeting. You can hear my voice is a bit sexy today, so I'm having flu. Just check my COVID, it was negative. So I won't show you my face. Okay, let's share my slide first. Can you see my slide?
Not yet, Prof. Oh yes. Can.
Can you see, right?
Yes, yes.
Okay, so going to talk about complication of lung cancer and how we manage. So the complication of lung cancer, it could be due to cancer itself, and it could be direct extension of the cancer. I think you have seen many with pleural effusion, rib erosion, which mainly just cause pain, and usually have not so much of concern. Superior vena cava obstruction is a medical emergency. We'll talk about that later on. Okay, it can spread to the heart, causing pericardial effusion. Again, we won't talk in detail because it's not that common. If there's a pericardial effusion, what you do is to refer cardiologist, have an echo done. If the effusion is serious, usually the diameter is more than 3 centimeters, and the patient usually requires drainage, especially there's evidence of tamponades, pericardial tamponades. Okay, then the pericardial drain can be done. And then, of course, it can cause nerve compression, like phrenic nerve compression, causing diaphragmatic paralysis. So, but again, it's not really so serious usually. Or it can be due to distant metastasis, mets to the brain, bones, liver, adrenal, and etc. The most concerned one would be brain and spinal cord. We're going to talk about that in detail later on. Non-metastatic or paraneoplastic. This is what you all asked me to talk, but I'm going to talk to you about SIDH. We may touch a bit about hypercalcemia, maybe. And other complications of lung cancer are mainly due to the symptom, like massive hemoptysis, airway obstruction, etc. Of course, it could be due to treatment-related complications. I'm sure you know that a lot of lung cancer patients come with advanced stage. Usually we give them chemo, immuno, or targeted therapy. And there are various side effects of chemo, especially neutropenic sepsis. I think all of you should know about how to manage, how to diagnose, and how to manage neutropenic sepsis. It's a lecture on its own, so I'm not going to touch this. And some of the immune-related side effects, okay, and it's called immune-related adverse events, and some people call it immune-related itis because it's inflammation of the organs. We're going to talk this a bit later on. Post-radiotherapy, which can cause esophagitis because you irradiate the mediastinum, the esophagus is there, and the patient may have pain during swallowing. And of course, it can cause esophageal stricture as well. And when you irradiate the lung, the tumor, the surrounding lung may be affected, so it can cause pneumonitis. Also, commonly, breast cancer patients have a radiotherapy. They may have pneumonitis as well. And of course, dermatitis, you burn the skin, okay, because the radiation will pass through the skin. Post-surgery, not that common. We send lung cancer patient for surgery, but if we send the patient for surgery, of course, these are the complication, infection, fistula formation, pulmonary embolism, etc., which is quite common complication of any surgery. Okay, we are going to discuss some of the common complication, and then using case study, I will show you some cases that we have and how to manage all these patients. And we won't discuss much about pain and palliative treatments. So direct extension of the tumor, as I say, one of the most common one is malignant pleural effusion. And most of the malignant pleural effusion are due to lung cancer, breast cancer, and ovarian cancer. You know that breast cancer, because direct extension from the breast to the uh, pleural cavity. Ovarian cancer can cause, of course, metastasis to the pleura and causing malignant effusion, or it could be another one called MET syndrome, which there's a pleural effusion associated with ovarian cancer, and pleural cytology is usually negative. Okay, how the patient present, I'm sure you know, patient will complain of shortness of breath, autopnea, and cough because of the effusion. And diagnosis is quite simple. I'm sure you know that we will do pleural cytology, and a lot of time, the pleural cytology may yield malignant cell in up to 70% of the cases, not 100%. So sometimes you do pleural cytology is negative, you may need to do thoracoscopy guided pleural biopsy, which we are doing in HDA as well as SUSMED. And we actually introduce a scope, special design scope to the pleural cavity, and you can see the nodule itself. Because sometimes in patient with malignant pleural effusion, there may be only very few nodules. If you do blind pleural biopsy, of course, traditionally we do blind pleural biopsy using the needle called Abram needles. You can Google how Abram needles look like, but you may miss the lesion because the lesion, if it's very discrete, the needle may not hit the lesion unless the pleural nodules in the pleural cavity is diffuse, is everywhere. Then there's a chance that you can diagnose by blind pleural biopsy. Usually, blind pleural biopsy and pleural cytology is almost the same yield. Yields mean the percentage of the patient who have positive result after your diagnostic tool. Okay, so it's about 70%. So pleural analysis in a patient with malignant effusion commonly is exudative. I'm sure most of you know that sometimes, occasionally, it may be transudative, even though the cytology is positive. So it still could be transudative. And usually the pH can be low, yeah, but it's not as low as bacterial infection. And the sugar also can be low. When the sugar is low, pH is low, it tells you just a lot of malignant cells inside the tumor. That's why it consumes a lot of glucose and then excrete a lot of lactic acid. Okay, and the cell mainly are lymphocyte predominant. This is typical of malignant pleural effusion. So how do you manage a patient come with pleural effusion, which is severe enough, or even is small effusion? You don't know what is the cause. You of course will do pleural tap. But if you already know this is malignant effusion, so you still want to relieve the shortness of breath by just doing a pleural tap, maybe. Um, I'll talk to you which type of patient you probably would do pleurodesis or indwelling catheter later on. Um, what you can do is you can do under ultrasound guided. That's the best. Now, international guideline actually recommends to do under ultrasound guidance so that the chance of you hitting the lung is less, because if you don't do under ultrasound guidance, sometimes the patient who have a lot of adhesion, the lung may be adhered to the chest wall and there were loculated effusion. If you look at the chest x-ray, you may not able to tell, but when you put a needle in, you may hit the lung. So that's why it's the best to do under ultrasound guidance. And every time, maximum you can drain only 1.5 liter. You put a chest tube or a chest drain, and at one time when you drain, maximum 1.5 liter. It's because you don't want sudden drop or intrapleural pressure. If there's a sudden drop or intrapleural pressure, the patient may get pulmonary edema. And this is what we call re-expansion pulmonary edema. So to avoid that, don't drain so much. Okay, when you see, especially a patient with massive pleural effusion, the effusion is more than 2/3 of the hemithorax. When you put a chest tube in, the fluid will gush out very fast. Within minutes, it will be more than 1.5 liter. So you have to prepare a chest clamp just to clamp the chest tube when 1.5 liter came out. Then you just hold on until probably 6 to 8 hours later. Then you open up your chest tube and drain another 1.5 liter. That's what you're supposed to do. Okay. If you're not careful, you drain too much, the patient can develop pulmonary edema and become breathless, and sometimes require ventilation as well. Unfortunately, most of the patients with malignant effusion, after you drain, it will recur again unless you treat them with treatment. And if you give them immunotherapy is well known to cause more inflammation initially. So if you give immunotherapy, it may cause further inflammations over the pleura. The effusion may actually become worse. Okay, so what's the definite treatment for malignant pleural effusion? Of course, you treat the cancer. You know, if the patient is suitable for targeted therapy, that is the best. Usually they respond very well to the treatment. The effusion may not come back again. So in this sort of patient, you may not need to put a chest drain. You may not need to, if let's say they come with moderate effusion, what you need to do is just drain out 1.5 liter. Then after that, you wait for the cytologist to come back, send for all the driver mutation testing. Let's say it turn out to be having a driver mutation. I'm sure some of you have seen EGFR, epidermal growth factor, turn out to be positive. Then you can treat them with targeted therapy. Okay, and usually the effusion will not come back again. It will resolve. If let's say you don't have a very effective medication, so a lot of time the patient will end up with pleural disease or enduring catheter. So what is pleural disease? Basically, it's installation of sclerosant, okay, into the pleural cavity, either through the chest tube or through the scope, thoracoscope, and that will promote inflammation and causing the two pleura, parietal pleura and visceral pleura, to adhere together so that the effusion will not reaccumulate. So that's the role of pleural disease. And is it not suitable when the patient have a few conditions, like for example, especially when the pleura, the visceral pleura, parietal pleura and visceral pleura are not stick together. Okay, if you look at the chest X-ray, still got loculated effusion, or when there is pneumothorax. So these are patients, there's no point to do pleural disease because the two pleura are not adhere together. So when this thing happens, is because of the lung is trapped. The lung cannot expand fully. So like for example, when there's airway obstruction, you know, due to the endobronchial tumor, or there's an extensive intrapleural tumor masses. So you know, the pleura is so thick and there are a lot of masses. So that actually prevent the lung from expanding. Okay, like I told you, multiple loculation as well. Okay, or thickened visceral pleura because of fibrosis. So all these patients, you can't do pleural disease. What are the sclerosant that we can use? The common one used in our hospital is tau. Okay, sometimes you can use doxycycline, which is quite good, or you can use providone iodine as well. These are the free available in district hospital. So next time when you're in district hospital, you can use either doxycycline, 10 capsule or 1 gram of doxycycline. The doxycycline that we actually give to patient to swallow, okay? And of course, you know, doxycycline is antibiotic. So it's good that if you accidentally induce some Staph aureus, the doxycycline will kill the Staph aureus as well. Okay, based on Cochrane review, the best is do under thoracoscopy guidance rather than instill the sclerosant into the chest tube. So another way, especially when the lung is trapped, cannot expand, then you can put this long-term enduring catheter. So basically, you're just putting a catheter, just like a Tancock catheter, into the Tancocks go to peritoneum cavity. This is going to pleural cavity. So of course, it's very effective. It's just like a chest drain. Okay, the only difference is this catheter, we are not just directly go to the pleural cavity, we tunnel through, tunnel. So we do what we call tunneling. Okay, it's just like Tancock catheter. Also, the nephrology actually do tunneling. Mean you bury part of the catheter inside under the skin so that it will not come out easily. Okay, so that's what the enduring catheter. So good thing is it's actually very effective to relieve the dyspnea, but unfortunately it causes a lot of complication. Like as usual, you know that you put a foreign body inside the body, you can get infection, skin breakdown, cellulitis. So sometimes the catheter get blocked, and or you introduce bacteria, it cause empyema, and also the tumor can spread through the catheter tract, so causing a lot of pain to the patient. Okay, and Sometimes after you put indwelling catheter for a long time, so the pleura will get inflamed and then it will stick together. So the spontaneous pleura disease is very common after you put indwelling catheter. So after many months or years, you can probably take out the indwelling catheter. Okay, I promise you to talk about SVC obstruction, which is very, very common. We will see 1 to 2 patients a month that come with SVC obstruction. I'm sure you know how the patient looked like. Not long ago, I just showed some of you a patient in HDA with SVC obstruction. So you'll see a lot of dilated veins over the chest wall and the neck, and you can even check the direction of the flow. And with SVC obstruction, it will flow downwards. Okay, and patient will look plethoric. The face will be swollen and red, and both upper limb will be swollen because SVC drain head and upper limb venous system. So not only the face and the neck, the most important thing is the renal can become edema and the brain also can become edema. Okay, so that's why in SVCO, it's a medical emergency, especially when the patient has grade 3 and above, you know. So you can confirm by CT scan, not that difficult to make the diagnosis of SVCO. Anytime when you see a patient with SVCO clinically, you need to order CT scan urgently. You cannot wait for the appointment, which is take usually 3 to 4 weeks in the general hospital. Just get an urgent CT scan. And as I say, the most common is due to lung cancer. The second most common is actually lymphoma. Okay, this is a classification how we classify SVC obstruction. I don't think you need to remember the classification, but just remember the grade 3 or which fall into severe, because severe means you need to do emergency intervention. You cannot wait. You wait, patient will collapse in front of you. So these are when the patient have headache, giddiness. Why in the headache and giddiness? It's because they got cerebral edema. Okay, or they have dyspnea. Okay, and they have syncope after bending. Okay, then this is tell you serious. Of course, the most serious one, they when they have stridor, they become confused and syncope, and of course finally they die if you don't do anything. So these are in a serious condition. So it's emergency. You got to act very fast. Otherwise, the patient will collapse within 24 to 48 hours. And what are the treatment if you get a patient who has SVCO? So it all depends. The most effective treatment is stenting. We refer to Prof. Razali. Prof. Razali is doing IVC stenting. Sorry, SVC stenting of the superior vena cava. And the efficacy is about 95%. It's very effective. Almost all patients will respond to SVC stenting. Okay. Then it depends whether it's small cell lung cancer or non-small cell lung cancer. Small cell lung cancer respond very well to chemotherapy. So you can actually give the patient chemotherapy as soon as possible when you diagnose SVC obstruction with histology. Non-small cell lung cancer, they don't respond so well to chemo. So you better give them radiotherapy first. And of course, if they got targets, like I told you, EGFR positive or ALK positive, then you can give them targeted therapy, which is very effective for patients who have non-small cell lung cancer with so-called driver mutation or special mutation. Okay, yeah, bear in mind it can recur after your treatment, so you have to watch for recurrence. Steroids definitely is very useful in SVC obstruction. And before you get all this, when you have patient come with SVC obstruction, so a lot of time to get CT scan. After the CT scan, you straight away can start the patient on dexamethasone, and this is a dose 60 milligram per day or 8 BD usually IV. In the patient in the hospital, usually patient with grade 3 and above SVC obstruction, we will not discharge the patient. We keep the patient in the hospital. Okay, then you need to get biopsy done. So steroid is still the first line treatment. Then after that, you get biopsy done. So once you confirm whether it's small cell lung cancer or non-small cell lung cancer, you can treat appropriately because the histology usually take about 3 to 5 days to come back. Okay, let's talk about massive hemoptysis. So some of the lung cancer patients actually present with massive hemoptysis. This is a definition. If you cough out 200 ml of blood, it's considered massive hemoptysis. And you must understand one thing, 400 ml of blood is enough to flood the airway and the patient may die of hypoxia. Okay, and the blood clot can obstruct the major airway as well. So in massive hemoptysis, as I always mention, the patient don't die of shock, the patient die of hypoxia, respiratory failure. Okay, they don't die of shock. Okay, So not like the GIT bleeding, the patient will die of shock because the gut can accumulate a lot of blood. Okay, but in lung, the most common cause of death is actually respiratory failure. So that's why the principle of treatment may be a bit different. So first, you want to maintain adequate oxygen. This is the most important things. So you get a patient who come with massive hemoptysis, patient is hypoxic. First thing to do is intubate the patient with large bore ET tube. Okay, so that you can successfully suck out all the blood. Okay, try to place the patient in lateral decubital positions. With affected lung, if you know the bleeding part is on the right lung, then the right side will be on the bottom, the left side will be on the top. So logic, it's just so that the blood will just flood at the site of bleeding. Okay, it will not affect the site which is not bleeding. So you can ventilate the site which is not bleeding. Okay, if this unilateral lung bleeding from one side of the lung, but if you're bleeding from both sides of the lung, like diffuse pulmonary hemorrhage, then it doesn't work by changing the position of the patients. Okay, there's another double lumen ET2 also useful if you got bleeding on one side of the lung. And this double lumen ET tube, basically it just got two lumen, so it isolate one side of the lung from another side. So the bleeding side, you can let it bleed, and then of course you can keep on sucking out the blood on the side that is bleeding. The other side, which is not bleeding, you can ventilate the patient efficiently. So this is what double lumen ET tube is about. Okay, treatment. Of course, if it's due to tumor, you already know. Let's say this patient diagnosed with lung cancer, while waiting for surgery, patient come with massive hemoptysis, you can send to the surgeon and get resection done. But commonly, a lot of patients come in without diagnosis, first presentation, or even they have diagnosed already, they are advanced stage, not suitable for surgery. In this group of patient, if you want to stop the bleeding very fast, pulmonary angiography is one of the options. If you got intervention radiology in your hospital, you can refer for pulmonary angiography. So the radiologist will find where is the bleeding point and will try to do coil embolization to block off the bleeding point. Or else you refer to us with chest physician, we will do bronchoscopy. So why we do bronchoscopy? First, we determine where is the site of the bleeding and where is the source of the bleeding. Okay, a lot of time it may not be due to lung cancer, it may be due to some other diseases. So by doing bronchoscopy, a lot of time we can tell where is the bleeding site. Is it from left lung, right lung, or bilateral, or is there any lesion in the central airway? Okay, so if there's a blood clot, we can remove. We can also see whether the bleeding has stopped. The question now is there are two ways to do bronchoscopy in a patient with massive hemoptysis. One is using rigid scope. We are doing rigid scope in UIA hospital. We just did one few days ago. I'm not sure any of you have seen it. And flexible scope also is possible. So the general principle is quite easy. If the bleeding is actually from the mucosa that you can see, like in the central airway, trachea, left and right main bronchus, and the segmental bronchi, then what we try to do, we produce heat to coagulate the lesion. Okay, we have laser in UIA hospital, and electrocautery is of course present in all hospitals, and APC, I think you forget about it. It's called argon plasma complex. We do have before, but I think the machine was not functioning well. If it's peripheral lesion, what you can do is just block off the segment which is causing a bleeding. Okay, you can use many way. Tip of the bronchoscope, balloon. There's a special design balloon for that, or there's a special design spigot. It's called water nut spigots. Can use to block off. I don't think you need to know all this in detail. I just tell you the basic principle. Okay, these are a bit specialized. Only chest physician need to know, I presume. Okay, but I just need you to know that these are what we do. So that's why you can refer early. Okay, I don't think I'll go through detail for this one. Just show you a case of our case. This patient is from HDA, massive hemoptysis, CA lung. We diagnosed left upper lobes, and initially the tumor is just left upper lobe. After the patient had massive hemoptysis, you can see the whole left lung collapse. Okay, initially the left lung was not fully collapsed. It just got a tumor on the left upper lobes. So because of bleeding, so we finally transfer the patient to SUSMED. What I did was I did a rigid bronchoscopy. So it's got a tumor arising from the left upper lobes and protruding to the right main bronchus. And there's a lot of clot there in the main bronchus. That's why the patient actually having a respiratory failure, require ventilation. So what we do is we actually call out all the tumor and we put an airway stent inside. So when we put an airway stent, because the tumor is actually bleeding from the right upper lobes, so I put the airway stent all the way stand to the so the stent go to the lower lobe bronchus. So you can see now there is a gas or there's a air in the left lower lobe bronchus. Upper lobe you cannot save it because it's all filled with tumor. Okay, so at least with that the bleeding stop. Okay, that's how we stop bleeding. Okay, let's talk about complication due to metastasis. The most common brain metastasis is very common. Any cancer can mets to the brain. A general principle of treatment is the same, whether it's lung cancer, colon cancer, breast cancer, or whatever go to the brain. It can be one, it can be three, it can be multiple. The treatment, the most important is steroids. Okay, it work very well, especially when there's a perilesional edema. A lot of time you look at the tumor is very small. Just look at this scan. See, the tumor is very small. It's probably about 3 centimeter, but the edema is a lot. You can see this black color here is edema. Okay, and here as well. Usually, when there's a mass, this multiple tumor here is enhanced with contrast, and you can see a lot of edema here. Okay, this one is a central. There's a cavity because the tumor commonly causing central necrosis. Okay, and there's edema as well. You can see here, very ill-defined margin. And then the color is not so dark. I will show you one later on and see what do you think this is. Okay, this is also edema. So a lot of time, because of the edema, you get DEXA. It's just like SVC obstruction. When DEXA is very good for edema, it doesn't kill the cancer cell, but it reduces the edema. So a lot of time, today you start DEXA for patient left-sided hemiparesis, say for example. The next day you can see patient walking at it. You know, if the patient comes with cerebellar sign, you know, the next day after you give DEXA, the patient can walk without much of imbalance. So that's how effective is DEXA in patient with brain mets. If the patient just have one lesion, very periphery especially, you can refer to surgeon, our neurosurgeons. They usually do a resection. Okay, but a lot of time when the patient have brain mets, they have multiple. So when they have multiple, the definite treatment will be depend. Okay, if the patient you think that is going to be respond well to targeted therapy, then you give targeted therapy first and see how. Okay, or else you refer to oncologists. They will do either whole brain radiotherapy or stereotactic radiosurgery. Okay, depend how many lesions there are. That one I think is probably too high tech for you. I'm not sure whether any of the oncologists teach you about this. But if SRS generally for smaller lesions, less than 5 maybe, less than 3 centimeter. But whole brain RT, if there are multiple, more than 5 lesions in the brain and multiple, and some of them are big, so you can do whole brain RT. Okay, we talk about spinal metastasis. So other than bone, I thought I had a few more slides after this. Never mind, it's okay. Spine mets also is common, so it can both match to the bone, the vertebra, and causing compression of the cord, or it can match straight away to the spinal cord, or what we call intramedullary metastasis, usually associated with pulponosis, or it match to the meninge or epidural of the spinal cord. Okay, so it can, I mean, most common is still bone, match to the bones, and then causing collapse of the vertebra and sometimes causing cord compression. Again, this is a medical emergency. When you have cord compression, you must understand the longer the cord compression is, the poorer the outcome. The neurological sign, the paraplegia over the lower limb may not recover if you actually wait too long. Okay? Of course, the patient may have pain, so you analgesic for pain relief is very important. And I told you DEXA also is very important. But for cord compression, sometimes we may need to give higher dose. Okay? The same thing is because when there is a spread to the cord or cord compression, there usually some edema. So that's why they will respond well to DEXA, but not as well as patient with brain mets though. Okay? So once you diagnose the patient have secondary to the spinal cord or to the vertebra causing cord compression, you will discuss between surgeon or orthopedic surgeon as well as the oncologist, which is the best treatment. So they have some algorithm to decide whether surgeon should go in and do decompression surgery. And there's a scoring system also. I think you can ask Prof. Zamzuri for that. And or radiotherapy. Okay. Of course, If the patient have suitable targets, a targeted therapy sometimes can be very useful. If I got patient with EGFR positive with cord compression, I will sometimes tell the surgeon, yeah, you can list a patient for operation. Let me start treatment first. You give me a week. If the patient don't respond, then you go for surgery. But sometimes after 1 week, you can see patients start walking already. So that's how good if the patient have special targets that we can target. Okay, just show you a case of my this lady. Actually, still remember saw her many years ago, and she's 40 years old, non-smoker, presented with bilateral limb weakness, both upper limb and lower limb, as well as weight loss. And this patient was ended up in district hospital, and the CT brain show multiple brain secondary. You can see multiple lesion in the brain with edema, but the edema is not too bad. You see, only this nodules there is a lot of edema. The rest hardly any periditional edema. Okay, the clue here is this patient had bilateral limb weakness. Okay, in fact, this case was not referred to me directly. It was referred to a neurologist, Dr. Sulaila, and Sulaila showed me the CT scan, asked me, and it was reported as tuberculoma. You know, when I saw the CT scan, I said, no, this is not tuberculoma because tuberculoma usually won't cause so much of edema. I said, this is secondary. Then she told me, yeah, look at the X-ray. There's a mass in the lung. So, and the mass doesn't look like TB. It's not like consolidation, cavity, you know. No doubt it's upper lobe. So that's why I make them think it's TB, but it's actually not TB. So I brought over the patient the next day. In HDA, we biopsy the patient. And subsequently, I sent the patient for MRIs urgently. I said, remember at that time, MRI in HDA was down. So we sent this patient to SUSMED, managed to get urgent MRI. So this patient actually have a tumor in the spinal cord as well. So that's why when you get tetraplegia with sensory level, it cannot be, unlikely, I would say cannot, due to brain metastasis. Unless the lesions just happen in both motor cortex and also both you know about homunculus, like in the medial part of the, it just happens sitting there too, you know, so it's like the chance is very very slim. So most likely it's actually spinal cord. Okay, sad to say that this patient actually was admitted to, in fact she have actually numbness over the lower limb for 3 months. Went to KK, and KK doctors cannot find anything as usual lah. Okay, I don't know how they examine the patient, but they just sit on the patient, just send the patient for physiotherapy until the patient cannot walk. Power was 3. Patient was admitted to one of the district hospital. Unfortunately, patient stayed 1 month in the district hospital before patient was discussed with us. So when the patient come to see me, when I saw the patient in the scope room, the patient power was almost 0 over the upper limb and lower limb. Okay, and this patient have a very nice sensory level. So that's what I think I presented this to the one of the conference yesterday, just to remind doctors, don't ever just trust the CT scan. Always do clinical correlation. You know, you cannot, your clinical diagnosis is tetraplegia with sensory level. This got to be spinal cord. It cannot be brain lesions. Okay, it's very unlikely. I would say I cannot say 100% cannot be, but it's just unlikely. Okay, so in this case, patient actually biopsy show ALK positive. ALK positive is one of the driver mutation, and so the treatment is just this tablet called selatinib. So I give her selatinib, and you know, CT brain done 3 weeks later in SUSMED, it was reported as normal. Means the tumor is totally gone. Okay, we also listed her for MRI spine. Unfortunately, she had sepsis at that time, so an MRI spine was cancelled or postponed, and we managed to get CT TAP. You know, it's easier to get CT than MRI in the government hospital. So we get 2 CT scan done. A CT scan of the lung mass also reduced more than 50%, but unfortunately, her power never improved. Her power was persistently 0, and she came to us that time. She already got bed sore at the back. You know, finally she died of sepsis because of very bad sore. 40 years old, lung cancer, supposed to be treated. This ALK positive lung cancer, 5-year survival is 60%, even though it's stage 4. A lot of my patients coming with brain mets, you know, coma. After I give ALK inhibitor, they live more than 5 years. But unfortunately for this patient died. Of course, I'm sure you know why the patient died. Who is at fault? Okay, just show you some nice CT scan. We saw in HDA not long ago, a patient with lung cancer confirmed, and with brain mets also confirmed, and come in worsening of left-sided hemiparesis as well as headache. This is a CT scan done, urgent CT scan. So this patient was admitted to neurosurgical ward there. So what do you think? Anybody want to offer any answer? I've been talking, so you all can talk. Now, hello? Are you all still with me or the internet already down? I'm talking to myself for the past 1 hour or so.
Yeah, we still sure.
So what do you think about the CT brain? So remember I showed you the edema, right? Do you think this is edema? Look at the color of the opacity here or hypodense lesion here. This is edema. Do you think it's the same here and this one? This lesion. You can see midline shift, right? You can see here the ventricle have been squeezed. So there's a midline shift already. Okay, that's why the headache is quite bad. So what is this?
Tolong kawan. Where?
Oh, you're going for exam, right? Anybody want to offer any diagnosis?
Very severe brain edema.
As I say, the color is not the same as edema. This is even more hypodense than edema, and the margin is very, very, very defined, well defined, and it's rounded. Okay, fine. This is cystic metastasis. The tumor has spread to the brain and causing a lot of necrosis to the brain. So it has liquefied, okay, so causing mass effect. So the best treatment for this patient is actually to drain out. So that's why it's how important it is to make the diagnosis correctly and do it correctly. Unfortunately, this patient also was making a wrong diagnosis. So radiologist report as edema. So the surgeon was sitting on it until I saw the patient. I told them this is not edema, this is cystic metastasis. And I confirmed with our neurosurgeon in SASMED. They also say the same thing. And of course, when I consult them, I don't tell them I think it's cystic metastasis. I just ask them, what do you think this is? They told me it's cystic metastasis. It's consistent with my diagnosis. Okay, so this patient should be drained. How about this one? This patient, lung cancer, coming with headache. Treated with chemotherapy and all these things. Initial respond very well, and later on come with headache. So what's your diagnosis based on the CT scan? Any offer?
Cerebral atrophy. Dia punya ventricle dia besar.
When the ventricle is besar, it can be atrophy or it can be. You look at the south side. Will the south side look big? So in ventricular atrophy, the cerebral atrophy, the south side also is big. Okay, but this one is not big. The south side is quite normal.
Oh.
Okay. So what's the diagnosis? You understand what I mean or not? When you get cerebral atrophy, yes, the ventricle is big, look big, and the south side also look big, but this south side is not big. Just the ventricle is big. So what's the diagnosis?
Hydrocephalus.
Yeah. So how do you treat hydrocephalus?
Shunting.
Yeah. What's shunt? VP shunt, okay? So you send the patient to surgeon and do VP shunt. So this patient of mine had a VP shunt after that. Okay, it's complication. This is what you want, right? Paraneoplastic. The most common is SIDH. And I'm sure you know abnormal secretion of ADH. Frequently, the patient is asymptomatic. The sodium, if it's very low, usually 1, 2 something. So that's why the patient most of the time no symptom. But when it drop below 120, then the patient start to have lethargy, weakness, confusion. Let's say it's less than 110, and delirium and seizure. Okay, how to diagnose SIDH? Serum sodium usually is less than 130, and serum osmolarity you can calculate. Yeah, you know how to calculate. There's a formula to calculate serum osmolarity. Usually is less than 280. And despite that, they have highish urine osmolarity, because you expect when the patient have such a low serum osmolarity, the urine osmolarity would be less than 100, but it's more than 100, or some books say 150. Okay, and the urine sodium also is high, more than 40. So that's unusually high for a patient who has low serum osmolarity. So that's how you diagnose SIDH. Treatment, very simple. Just need to restrict the patient. For lung cancer, a lot of time just with fluid restriction, I think almost 100% of the time, I do not need to give any hormone to the patients. Okay, I just give them fluid restriction, 1 liter a day, the sodium will slowly go up. Don't overcorrect the patient. I start seeing a lot of doctors start giving hypertonic saline, unnecessary. Okay, and the patient is very well, unless they come in coma or they have seizure in front of you, then you can use hypertonic saline to fast correct. Okay, don't forget that if you correct too fast, then you can get this what we call central pontine melanosis. We associate with hypoponosis. There's no treatment for that. Patient will be tetraplegic forever. Okay, so be careful about your hypertonic saline. Don't simply use hypertonic saline unless it's emergency. So this is SIDH. I didn't prepare any slide for hypercalcemia. I think probably we just talk a bit about hypercalcemia, which is also common. Hypercalcemia usually due to either PTH-related peptide, usually associated with squamous cell carcinoma and causing hypercalcemia, or it could be more commonly is due to bone metastasis. And you will know alkaline force is high, calcium is high, you know, due to bone metastasis. You do bone scan or sometimes CT, TAP also can tell you there's a lytic lesion or sclerotic lesion in the bone. Or you do PET CT scan also can see bone secondary. Okay, so a patient with hypercalcemia due to bone secondary, if they come in to you, usually they are dehydrated. Of course, very rare they come in coma or whatever. They usually come in dehydration, a bit of acute renal failure, but usually not too bad. How do you know acute renal failure? They are due to hypercalcemia is pre-renal renal failure. So urea is in proportional higher than creatinine. So the urea may be 5 times the normal range, but creatinine is only 3 times the normal range. So you know that this hypercalcemia really cause acute renal failure, okay, which is a pre-renal renal failure. So how do you treat? Hydrate the patient. We usually give a lot of fluid, 8 liter to 1 liter. But of course, in an elderly patient, you must be careful when you pump in so much of fluid. The patient may go into pulmonary edema. You probably need some form of monitoring, either CVP, central venous pressure monitoring, or pulmonary artery wedge pressure monitoring, or at least nowadays people use echo to monitor. But it's very tedious, so you need to send patient for echo every day to check fluid status. So you give them drip. The thing is, this drip will actually come out in the urine, right? So it will take out the calcium. So by giving drips, usually the calcium will drop slowly. And on top of that, usually we need to give them biphosphonate, okay, either palmidronate or lindronate or etc. So all these drugs will actually bring down the calcium, but it takes few days, 72 hours to reach a maximum effect. So that's why you still need to hydrate the patient first in the patient with hypercalcemia. Okay, you monitor the patient renal function as well as calcium every day, so you can start seeing calcium coming down slowly. Okay, and if the patient had bone metastasis or even PTH-related peptide, so usually this patient the calcium will rebound after you treat them. So usually we give them palmidronate or biphosphonate every 3 to 4 weekly. So usually we give together with chemotherapy. If the patient not on chemotherapy or targeted therapy, you can give them every 4 weekly. Or some people even give 8 weekly, depend, because you give too much, the patient may get hypocalcemia. Okay, so that's about hypercalcemia. The others are not very common, and it's endocrine disorder. You can get ACTH-related peptide causing Cushing, but usually there's not required treatment. We just treat the underlying disease. If the patient have hypoadrenalism, but that is not due to paraneoplasty. It's actually due to mass to the adrenal gland. Again, it's not common. You just need to send cortisol level, or you do a synectin test. In the synectin test, the cortisol level doesn't really go out to more than 550 nanomole per liter. Then you know that this patient has hypoadrenalism. Then you can give the patient replacement of cortisol acetate oral. Okay, but if the patient in stress condition, then you change to IV. So that is for hypoadrenalism because of bilateral adrenal metastasis. What other paraneoplasty if you want to know? But the rest are not important. Hyperprolactinemia causing gynecomastia and all this thing is of no clinical significance. And Eaton-Lambert syndrome, we see very occasionally, very rare. Eaton-Lambert is just like myasthenia gravis. The only difference is when you do a nerve conduction study, you should be able to tell whether it's myasthenia gravis or this is Eaton-Lambert, because the atom action potential will increase during stimulation in Eaton-Lambert, but decrease in patient with myasthenia gravis. Okay, there's a difference between these two, but all these are not very common, and I don't think you need to know in detail. Okay, let's talk about complication due to treatment. I told you I'm not going to talk about chemo causing neutropenic sepsis. You can ask Dr. Ismail to teach you that, or ID physicians. But generally quite simple. You need to bring out the what's that called, the neutrophil. So we will give GCSF. You know, GCSF is available in your blood as well. But in the patient come with neutropenic sepsis, we definitely need to give them extra GCSF. Okay. Then you need to give them broad spectrum antibiotics when the patient have neutropenic sepsis. There's a guideline. You can go and Google a guideline on what antibiotic to use. Okay. And usually probably combination of third generation cephalosporin with aminoglycoside. Or you can give them carbapenem as a single agent. So these are the common antibiotics that we use for neutropenic sepsis. Then you do culture. Don't forget there can be fungal infection as well. And if the patient don't respond well to antibiotics, you probably have to give antifungal. Okay, we talk about some cases of mine. This patient was given a drug called pembrolizumab. 10 months after pembrolizumab, the patient presents with dry cough and short of breath. What is pembrolizumab? Pembrolizumab is actually immunotherapy. So what is immunotherapy? Okay, this group of immunotherapy is called immune checkpoint inhibitor. It's not only treat lung cancer, but it's also treat many other cancer. So that's why I think you as a new generation doctor, you need to know about this drug. So eventually immunotherapy probably is going to replace chemotherapy, or at least give concomitantly with chemotherapy. So a lot of indication, it's just because the drug is very expensive, you don't see many doctors give it. You know, the drug costs about 10,000 a month. So that's why a lot of our patients cannot afford. Okay. I'm quite lucky because I do a lot of clinical trial. I use a lot of immunotherapy for the past 7 years. Even the drug haven't been registered, we have used it because from the clinical trial. So this patient was given 10 months of immunotherapy and developed cough and short of breath. And this CT scan showed typical of ground glass and consolidation in the lung. You can see nice air bronchogram here. Air bronchogram here. This is blood vessels. So it's got mixture of consolidation and this is ground glass. When we say ground glass, means you still can see vessel. Okay, like this part here, you cannot see vessel, then you say consolidation. And typical cardinal sign of consolidation is air bronchogram. Okay, here is more ground glass and it's diffused everywhere bilaterally. So what is this patient having? So this patient is having pneumonitis secondary to pembrolizumab. Okay, and treatment very simple. We just pulse them with methylprednisolone. Usually they will respond very well. In serious cases, if it's not serious, we just give them 1 milligram per kilogram of oral prednisolone. Another patient of mine who actually have 1 year of pembrolizumab, it's the same drugs, and he actually had bloody diarrhea. So he come in with diarrhea for 4-5 days, and we blood. Okay, so we emergently admit the patient, had a colonoscopy done, and you can see multiple cobblestone appearance and in the colons. So this is quite consistent with inflammatory bowel disease. Okay, in fact, my gastro colleague will say, "Oh, this is inflammatory bowel disease." I say, "No, this is not. This is pembrolizumab-induced colitis." Okay, it's based on literature. You cannot differentiate between these two clinically, and some histological may tell you, yeah, more likely to be immune-related rather than inflammatory bowel disease. But you know that when a patient given pembrolizumab or any immunotherapy, they are at high risk of getting immune-related colitis. Okay, so it's not only causing lung and this one, it can cause many other organs. So basically, what happened is when you stimulate this immunotherapy, actually stimulate our T lymphocyte to kill the cancer cell. It doesn't kill the cancer cell directly, so it actually stimulate our own T lymphocyte to kill the cancer cell. But as usual, it's just like autoimmune disease. Sometimes these stupid cells get crazy, and it's not only killing the cancer cell, it kills your own cell. It's just like autoimmune disease, Suddenly all the T lymphocytes go and attack your own cells, and you get pneumonitis, you get carditis, and you get arthritis, and etc. So it's the same thing here. So your immune system is too strong. That's why the treatment is steroid. You just give them steroid, it suppress the immune system. So it can cause what organ? Like I told you, this pneumonitis. I have patient with colitis. I have also patient coming with nephritis. They just got worsening kidney function. And the nephritis can be due to interstitial nephritis, or it can be due to glomerulonephritis. You need renal biopsy to confirm. I got patient who come out with thyroiditis. So usually they are suddenly T4 become very high, TSH is low. They are just like having thyroid toxicosis. Then subsequently they go hypothyroid because of inflammation, initial inflammation of the thyroid glands. So the T lymphocyte go and attack the thyroid gland, causing hypothyroidism. Subsequently, thyroid gland get destroyed and become hypothyroid. So long term, the patient become hypothyroid. Sound like what disease? Which autoimmune disease like this? Hyperthyroid, then followed by hypothyroid. Which thyroid disease?
Hashimoto thyroiditis.
Yes. So it's exactly like Hashimoto thyroiditis. So sometimes we miss the hyperthyroid part. We only detect the hypothyroid. So that's why when you give immunotherapy to the patient, you need to do 3 monthly thyroid function tests. It's very common. It's up to 10% of the patient will develop hypothyroidism after immunotherapy. Okay? And it can attack the eye, of course, uveitis, very common. You know that a lot of autoimmune diseases cause uveitis. And it can cause adrenalitis as well as adrenal. Okay, probably it didn't put out in this cartoon. It can actually attack your adrenal gland, causing addiction crisis. So the patient can present with addiction crisis, or it can attack your pituitary, causing panhypopits. So panhypopit patient, also panhypopituitarism, also present with addiction crisis. Okay, you see how nasty the drug? It can cause hepatitis as well, just like your autoimmune hepatitis. Okay, it can cause many type of skin condition, pemphigus, pemphigoid, Stephen Johnson syndrome, and etc. Okay, neuropathy, it can cause encephalitis, transverse peripheral neuropathy, all sorts. Okay, so it's the same like your SLE patient also can get any organ involvement. Okay, it's almost the same. So that's why I think you need to know, because this drug is going to use more and more, especially when the drug becomes generic. The drug is cheap, and as I say, it's not only treat lung cancer. It treat almost all cancer. It started with melanoma first. Second was lung cancer. Then now almost there are easily 10 cancer that you can use or FDA approved to be used for cancer treatment. Okay, a lot are combination with chemotherapy. So this is my last slide conclusion. Complication of lung cancer can be treated, but need to recognize. And some of the medical emergency, especially, I think you need to know. And the appropriate treatment is important to prolong patient survival and reduce their symptoms. That's all from me. Any questions? So it's 1 hour of the lectures. Very boring, right? Too long. Come on, any question? As usual, nobody ask question. Or all fall asleep already.
Dia lagi ada.
Okay, fine. No questions. You can continue your day. I don't know what else you want to do.
Yeah, so I think as for now, there are still not yet question from the members. But however, if after this they have question, they can contact you afterward. Alright. So with that, I would like to thank Prof. Hao for spending weekend with us and give overview on how to manage the complication of lung cancer. So with that, I think we end the session this afternoon with Farah and Noah.
Okay, bye. Thank you. Bye.
Okay. Thank you, Prof.
Thank you, Prof. Thank you, Prof.
Thank you, Prof.